Hi, everyone, and thanks again for the invitation to join you this afternoon or this morning. My name is Dr. Christine Cassidy, and I'm a registered nurse, an assistant professor, and a clinician scientist at the IWK and Dalhousie University. And so I'm joining you today from the land of Mi'kmaq, which is the ancestral and unceded territory of the Mi'kmaq people, also known as Halifax. I finished my Bachelor of Science in Nursing, where I became a registered nurse from the University of Prince Edward Island. And from there, I started working in maternal newborn care at the IWK. Became really interested in how we were using evidence in our practice as registered nurses to try to improve outcomes for families and newborns. And so at that time, I decided to go back to do my graduate studies to try and understand this a little bit more. So I completed my PhD in nursing from Dalhousie University. And then from there, I went on to dive into this topic even more about knowledge translation and implementation science. And I completed a postdoctoral fellowship at the University of Ottawa after that, before returning to Dalhousie, where I started my assistant professor position in 2019. So my plan for the next few minutes is really to walk you through why I've chosen this field of knowledge translation and implementation science, and a little bit about my program of research and the challenges and benefits of doing such close partnership work with the health system. So before we go into all of that, I think it's important to situate what my research focuses on, and really it focuses on the evidence to practice gap. And so why did I even become interested in this topic? I mentioned that in my practice as a registered nurse, I saw that maybe we weren't always using evidence in our practice. I knew of maybe other best practices that weren't being incorporated. And I wasn't alone in that. So some of you may have heard about this 17-year gap between research evidence that is generated and how long it takes to get implemented and used in practice. And that 17-year gap is quoted often. It's definitely an issue, but I'm going to shift your attention to three other numbers that I think are quite alarming. So the first is that on average, only 60% of care that is being provided to patients and families is in line with evidence-based guidelines. I don't know about you, but if I got 60 on a test, I wouldn't be super happy. It's not that great. And what's even more concerning is that 30% of that care that's provided to patients and families is some form of waste or low value. So it's not needed in our practice. And then most concerning is that 10% of care that's being provided has actually been found to be harmful. So that needs to be removed and de-implemented from our practice. So that's really where this evidence to practice gap has come in, and this focus on trying to bridge the gap between evidence and practice. You might also be wondering, okay, so we have this gap, describe some different numbers about how concerning the gap is. Why is there a gap to begin with? And so I think it's helpful for two different ways of thinking about this. The first is that we have a transfer problem. So maybe we as researchers or as students and trainees, we just aren't doing a very good job of getting our research evidence into the hands of those that need to use it. So it's that transfer problem of getting evidence into the hands of people that need to use the evidence. But also there could be a production problem. So maybe we aren't asking the right questions to begin with. And so as researchers, we aren't studying the things that are actually relevant and useful to whoever needs to use the research evidence. So we're generating lots of interesting findings, but it's not relevant and useful for the health system or for community partners. So my research program has really stemmed out of these two problems, but with definitely a primary focus on that production problem. So really, there's two main pillars to my research program that have stemmed out of this work. The first is to implement evidence-based intervention. So always working with partners from the health system, patient, family, and public members healthcare providers, and using what's known as a research co-production or an integrated knowledge translation approach. Really, those are just big words for working in partnership to actually design, implement, and evaluate evidence-based interventions and get those into healthcare practice and policy. So that's kind of the main pillar of my research. The second pillar always runs alongside that, where I'm looking to advance implementation science, theory, and methods. So what that means is that I'm really interested in understanding how to advance our understanding of how to implement and sustain evidence into practice and policy. So this type of research program, again, works in close partnership with the health system to get the evidence into practice while also studying the how-to behind that. And so there's definitely some challenges, but lots of benefits to doing this type of very applied, pragmatic research. So, this isn't something that I just sit in my office and come up with research questions that I think are interesting, and then I go and try to find funding and to do that research. Everything that I do really comes from the health system, and that includes health system administrators, healthcare providers, patients, caregivers, and families. So the questions always come from some type of priority within the health system, but it can be challenging because we also need to be strategic about our academic outputs. So I am 100% employed by the university. I have an affiliate appointment at the hospital. That just means that I am able to do research there. I can apply for research ethics. I can work with providers and patients at the hospital, but I am not employed by the hospital in my researcher role, and I don't report to anybody at the hospital in that sense. So my job really is academic, and I need to be strategic about doing such applied work, but also having academic outputs that can be shown on my CV and be seen as benefits from the kind of university institutional perspective. The other piece that can be challenging is that sometimes it takes a really long time to implement things. And so as a researcher, we apply for funding and we've got this beautiful Gantt chart timeline maybe in your grant, and it's all looking so nice. And you've got all these outputs that you're going to have, but this is really real world research. And so it can all go well, or it can all go not so well. And so being flexible and nimble is a really important part of doing kind of embedded partnership type work, and being okay that it's going to take time. And so it's oftentimes just making that clear, whether your academic performance review, or maybe you're going up for promotion, making it clear that partnership work takes time, but it's all part of the process. Despite some of those challenges, I think there's so many benefits to co-creating research evidence that I've experienced in my program of research. So I think one of the most beneficial aspects is that I get to see the use of findings almost immediately. So, having a research question that comes from a partner, an example is one of the partners that I work with is the coordinator for the Transition of Care Committee at the hospital. So that's a committee of youth, caregivers, healthcare providers that are focused on the transition from pediatric to adult care. And so, they came to me with a question. They wanted to know what are the barriers to that transition. So we did a qualitative study, and I remember doing the analysis with some of the youth that were on this committee. They were part of the analysis team, and they were just so excited about the findings, and they couldn't wait to bring them back to their committee meetings to share the findings and get started on designing some interventions. And so that really kicked us into high gear of making some type of infographic. It didn't need to be, the manuscripts come later, but some type of output that they could use to bring back to the committee meeting. So like I said, it really kind of puts the pedal to the metal sometimes with getting some type of output of the findings that can then be used. I also have seen such a benefit for trainees. So anytime I have a trainee who's interested in working within my program of research, They might come with an area of interest, which is perfect, but then we're always pairing them with some type of knowledge user, whether it's a patient, caregiver, health system partner, so that they can generate a research question that's related to some type of priority. And so trainees are really making an impact with their work in the same type of way. They're having a hard time keeping up with getting the findings into practice because they know what they're doing is useful to their partner in their research. And lastly, I think a real benefit to doing this type of work that I've experienced, despite some of the challenges, is that we're generating more relevant research. So we're able to address that production problem that I mentioned in the earlier slide about why there's an evidence to practice gap. So there's oftentimes this dichotomy of this concept of rigor versus relevance. So in order for research to be very rigorous, it maybe isn't as relevant because it takes time and we're putting boundaries and we're controlling for things. Whereas if you're really relevant, maybe you're in a much more flexible approach to your research. And I've thought about this dichotomy a lot, and I really do think that research can't be rigorous if it's not relevant. And so by doing embedded partnership type research within the health system, we're making sure that every research question comes from a priority, and then the findings that are generated will address that priority head on. So I think I'll stop there. Again, happy to discuss, share additional examples or insights, and answer any questions. Thanks.